Tapering. We tell all patients, you're going to get tapered. Oh my God! Especially if I just put you on it and they go, oh my gosh, I don't want to give it up. I'm going to hold on to this. Yeah, that's very normal, okay? Why we don't taper is because of fear of the practitioner and the patient. But the secret of tapering is simply give it time for receptors to recover, make the tapering amount a very small amount. You'll find some details in your handout on actually how to do it. Make it a very small amount, and you tell them, go ahead and try it and see if it works for you. They'll say, when do you do that? I may give them, if they're on 12 milligrams, I may leave them on that for 3 or 4 months. 3 or 4 is kind of a number I use. We'll taper it maybe 2 milligrams. So I take them from, let's say, 12 milligrams to 10 milligrams. Well, I saw them next month. Oh, God, I don't feel as good. I tell you what we'll do. Let's put you back on 12. I'll leave you on 12 for a couple months. Then we're going to give you a new technique. What's that? We're going to have you take 12 one day, 10 the other day, 12 one day, 10 the next day, 12 alternate days. The average will be 11. It'll be between the two. It will average out. Remember, it's a 3-day drug to stabilize. So use alternate day. And then after I say, when you've done this, and you've maybe in 3 or 4 weeks or a month or 2 months, you say, you can't tell which day it is. You feel the same on both days. I said, your receptors have already recovered. You're ready to move down. So tapering down should be a painless, it should be relatively, it should be very comfortable. If it's not, the cut's too big, it's too soon, they didn't have receptors back. And so if you do it right, it's a very smooth process. Now yesterday it's kind of weird. Yesterday I had like 4 patients, I think 4 or 5 patients at 4 milligrams, 3 milligrams, and 2 milligrams. Yeah, well, that took close to 2 to 3 years to get them there. It's not going to happen overnight. We've got lots of time. If we honor where these people are and honor the physiology of their brain, they will come down very smoothly and nicely. Now, I had a meeting today with one of our healthcare organizations, and I'm going to just pick on some people here. We'll pick on 4 right here. They've got 4 providers in their clinic. I said, who does the patient see? Well, they may see, I think you're on Monday, you got a clinic, Tuesday's yours, Wednesday's yours, Thursday's your clinic. Well, we don't know. It's going whenever they can come in or whatever provider they can see. So they asked me if we'd help standardize their care so that we'd have all of you practicing the same. I said, if we do that, it will help, but you're missing an important tool, and it's a strong tool. And it really helps to predict long-term success. Remember when we took that psych class and they told us about transference? Transference when you're the patient and I'm the doctor, and pretty soon we've been together long, you really trust me and I trust you, and now you're on a 3-month schedule, not a 2-week schedule, and we've been together for a year. It's transference. She's been with me for that. If she's seeing each of you, there is no transference. And that power of that provider, knowing that provider really cares for you and really cares about your receptors, that is a super powerful tool. And that's important to remember. So don't think of people as numbers. You can just see whoever's on call. In some of your clinical situations, you'll have to do that. But when you can avoid it, these people are in pain. They've been called addicts by their family, yet they've never had any addiction stuff. So tapering, but we tell everyone it's going to happen, and we're going to work with you. We teach our patients how to do the taper. My little spiel to them is rather simple. I say, we're going to teach you to do a trial drop about 2 weeks before you see me. This is what I drop. I want you to try it out. If it's working okay, cool. If it's not, we'll stay where you are for a while. We'll give it a try, see what happens. So we're going to teach you how to do it. Then I will look at, and this is just John Hart. I'll say, look, my job is to teach you to be the doctor. You're going to do the trial drops. You're going to tell me when it works and when it doesn't work. I'm going to get paid the same, and you're going to do all the work. They go, oh, okay, Hart, I know what you're up to again. I said, yeah. But every drop is a trial. You want to find out. We do about every 3 months. Now, what's that 12 versus 4? And that's simple. If I'm on 12 milligrams, you cut me 2 milligrams, you've cut me just a small percentage. If I'm on 4 milligrams, you cut me 2 milligrams, it's a 50% cut. The brain will go livid. Someone on 16 that I cut to 8, they'll go wild. Because it's a 50% cut. A 4 cut to 2 is a 50% cut. The brain is a percentage thing. It doesn't work on milligrams. It works on percent. So when you do a cut, think in percent. And tell the patient that. Because the lower you get the dose down till you're down in the 6 milligrams, it kind of starts about 8, 6 milligrams, 4 milligrams, on down. The cuts get smaller and smaller and smaller. The percentages. Okay. We give, well, I like to say there's some goals. At 1 year, you should be in the 8 to 10 milligram range. We see people all the time coming in. About 3 months ago, a patient from California, 24 milligrams, how many years? 5 years. Would they talk to you about tapering? They didn't. I go, oh. So we ask them, how do you take it? It was all done wrong, and we work on, then we help them. No one's maintained on 16. I think that's lazy medicine. We have had heroin addicts, we got all kinds of people, and we're not even at Lifeline, and we're not even starting them at 16 and it's working on. These are people with status post endocarditis and had a heart valve right here at Peace Health. And they're all maybe 12 milligrams and doing great. Okay. Interesting study. This is for those of you who are wondering, what should I maintain them on? And they're an addict, so I probably should use a high number because remember, practitioners fear, I don't want to lower it down, I'm afraid they're going to use. So I want to maintain them at a higher level, maybe 24 milligrams. Maybe that's what the doctor in California was thinking. Maybe it could be 12 milligrams. Here's what happened here. At this clinic, they were all maintained on 16. That was their standard. They had a cut in funding. They decided, what a wonderful time for an experiment. We're going to take part of them and leave them on 16. We're going to drop the other ones to 8. We're going to look at these people a year, 18 months later, and see what the differences is. And we know what's going to happen. The people we drop to 8 is going to have a big relapse uptake, and the other one's going to stay about the same as it's been over the years. No difference. So what happened is when they kept these people on 16, they probably had them on 16 for a year, so they didn't get the data for that. But they had enough receptors back when they dropped them to 8, it didn't make any much difference. So we see the single most common number in the clinic that we'll have people maintain on will be 8. Second most common number is 6. Next most common number is 4. And like last couple of days, we've had a bunch of 3s and 2s and that kind of stuff. Lowest one I had was 0.5 daily. And she was a high-level executive, and she was just fearful of coming off. And people will say, well, I want to get off of my Suboxone. You know, they've got a long-term history, and they want to get off their Suboxone. I say, look, I don't want to be maintained on this. I want off this drug. It's a narcotic. I say, look, Joe, I agree with you. You come in next week. Bring your cholesterol with you, your metformin, bring your hypertension pills. We're going to throw them all in the trash next Wednesday when I see you. Well, wait a minute, doc, we can't do that. I said, look, you can treat your gallbladder, you can treat your heart, you can treat your blood pressure, but we can't treat the brain. Okay, doc, I got the point, and then they're fine. And that's essentially what happens with Suboxone. Are we going to end up with a lot of people on Suboxone long-term for life? The answer is yes. Don't delude ourselves and think we're not. Can we get back all the receptor recovery of all the receptors? No. What happens to Suboxone at low levels? Suboxone at low levels begins to act like a full agonist. So you get them down to 2 milligrams or so, and it's acting much like a full agonist, not like it originally did at 16 milligrams. So when you know that, you don't get too upset by it. That's just the way it is. Suboxone is a fantastic drug for what we have done in our nation. But I hope it's not the last one. I want to see the next one come. I want to see that 100%. It's just not this drug. Okay, this actually has a lot more in this little statement than we can see. If people say to me on that first meeting, Doc, what's my chances of getting off Suboxone? Our first visit, we'll pick on you again, make the pain patient over here, the Mr. Clean. Okay? I'll say, well, tell me, I'll get 3 questions. I said, my first question is, tell me about your family genetics. I just care about grandparents, parents, brothers, and sisters. That's all I care about. Genetics only. That's all we care about. Any use of, I have a use of alcohol or pain medications on a constant basis for any reason. They name 2 people, but we commonly see this, oh yeah, my mom and dad and 2 brothers. That's genetics, okay? Now someone over here, I can tell by her look, she's a behavioral person. She's gonna say, no, that's behavioral, it's a bad environment. About a few years ago, there was a talk at OHSU, and oh God, what's her name? She gave a great a talk on rats, and basically, what we can take a rat, and in 3 generations we can get an alcoholic rat. So you take a normal curve of 100 rats, you're going to find a couple of those rats out of that whole bunch will prefer alcohol rather than water to drink. You take those, you breed those together, give them another generation, you got a bigger spectrum of them, take those, breed them together. 3rd generation, you got a rat that will go for the alcohol, vast majority of the time. So where'd your family meet? Well, let's see, my granddad, my grandma, they both worked in a bar, and 3 generations, you'll see it. Second item, we talked about that. Smoking as a teenager, why do I care? People, I'll say, a typical questionnaire, and we have it at Peace Health here, how much do you smoke? I said, I don't even care how much you smoke. I said, I don't know what age you started. Why do you care about what age? Well, did you smoke as a teenager or earlier? Well, yeah, I started at 12, you know. This is common to see at 12 and 14. If you, remember, smoking is dopamine on a stick. It's good for about 20 minutes, it's very amount. But if I start smoking early out there, I'm going to knock off dopamine receptors. My brain is not mature till mid-20s, and those receptors are gone forever. The person who says, I started smoking when I was in the Navy at about age 30, I say, I don't care, you can smoke 2 cartons a day. Lung doctor cares, cancer doctor cares, but I don't care. It won't affect it. So if they start smoking before the brain is mature, it's a predictor. Now, the research on that was interesting. It was done in about the mid-1960s. A whole little blast of things came out around the no smoking type thing. That's where it really came out, the no smoking thing. But one of the great studies I loved, it says, remember, cocaine is, in the experimental lab, cocaine is one of the best things we use because it gives a spike of dopamine. We can see it in the lab animals real easy. So if you smoke a pack of cigarettes a day at age 16 or earlier, and keep in mind that's fairly rare to smoke that much at that age, but if you do, your chances of using cocaine are 100 times normal. Not twice, not times 4. Opioids, it's smoking before the age, and these studies all cut off at age 16 to 18, it's somewhere between 2 to 12 times higher use of opioids if you're an early smoker. Just check your own patients. Ask them when they started smoking, okay? Now, the other thing that's an important thing is just how much exposure you have. A lot for a long term, you've knocked off receptors. We're gonna get them all back? No. We're gonna do a pretty good job, but it's not perfect, okay? Getting off Suboxone, I don't do it till they get down to the 2 milligram range. And then it's always their option. I never, ever tell a patient, we're gonna get you off Suboxone. I always ask a patient, would you be interested in trying to get off Suboxone? And it's always a trial, and I monitor them to see how they're doing. So if I get down there, here's what we tell them to do. For those who want to, and there's very few that would do this, I want you to start jogging or exercising for at least 6 weeks before, 5 days out of 7. I want your heart rate up, and I want you to get an aerobic workout. Okay? When you stop the Suboxone, what you'll do if you're on 2 milligrams, I want you to double your dose, that's in there, to 4 milligrams for 1 day, and then you stop. That gives them a slower taper. When you get kind of the heebie-jeebies for thinking about using clonidine and something like that on that, I want you to get out and start exercising again and get your heart rate up and see how you feel. And what they'll find out is it's produced by glutamate and norepinephrine. we use the blood pressure pill for the norepinephrine. It'll do zip with the glutamate. So glutamate is suppressed. It's an think of it as an activator. It's suppressed with opioid, and when you stop the opioid, the glutamate goes, wow, now's my time, and it comes roaring out, and you've seen them. They're like that. And I say, you go out and you exercise, it'll burn it off. And then it will come back about a couple hours later, and then you do it again. You do it 2 or 3 times a day if you need to. By 2 weeks, you'll be doing it maybe once a day or hardly at all. And when you see them in 2 weeks, you won't believe they're as close to normal as you're ever going to see. Now, how many people do that exercise thing? Actually, very few, because we're talking about human nature. But when it works like a charmer. So that's one thing. Low dose, double it up, get them to exercise if you can, and then follow them every month. And if they're dysphoric, so they went off, I'm going to pick a number here. They decided they wanted to get off at 4 milligrams. It's their call. I do it, I'll give them any withdrawal meds, whatever you normally would use. Give any withdrawal meds they want. And 2 months later, they say, Doc, maybe 3 months later, Doc, I still don't feel very good. I don't have any energy. The most common complaint after coming off opioids is I have no energy. I'm fatigued. I can't get off the couch. The acronym is FADS: fatigue, anxiety, depression, sleep. I can't sleep, but I'm laying on the couch all day because I have no energy. And I'm depressed. I hear any portion of those after someone's taken off of narcotics. And so I see this person 3 months later. He says, I'm off. I just have no energy. Okay, Joe, remember, it comes to the money back guarantee. We'll put you back on. Put them back on 2 milligrams, half the dose they came off of. In those few months, they'll get back more receptors, and it works 90% of the time. And they'll go back on it, 2 milligrams, just leave them on that till. They'll do that the rest of their life. That's okay. It's the best we got right now. So that's the secret to getting them off of that. Most you don't get off.